Hi, everyone, and thank you for joining us. I'm Dominique Bosshard, Game Plan Advisor at the Canadian Sport Institute, Ontario. Welcome to CSIO's webinar series, Podium and Parenthood, Fertility and Family Planning. And today's topic, the menstrual cycle, understanding your body's natural rhythms, brought to us by Markham Fertility. At CSIO, our purpose is elevating people and performances, both on and off the field of play, and focus on holistically and people first. So as athletes are staying in sport longer, we think that it's really important that you're informed about your options around family planning. And this is, of course, also sport folks, coaches, etc. And part of our newly launched Women's Health Initiative, CSI was really keen to work with Markham Fertility Center as a community partner to ensure that athletes have the information that they need to make those informed decisions. We're very grateful and thankful to Markham Fertility Center for their willingness and enthusiasm to share their expertise with us on the subject of fertility and family planning. For today's session, I'm so pleased to welcome Dr. Daphne Chung. Dr. Chung is a reproductive endocrinologist at Markham Fertility Center and is very passionate about enhancing patient experience through optimizing protocols, pathways, and education. So thank you so much, Dr. Chung, for being with us, and over to you.
Let's get started. Thank you for the invitation. Thank you for the lovely introduction. Today, I'm talking to you about the menstrual cycle, something near and dear to our heart, something that we practice every day as reproductive endocrinologists. And today we're going to talk about understanding your body's natural rhythm. I'm here on behalf of Markham Fertility Center, which is an amazing workplace. We are a 5-physician team. We're all reproductive endocrinologists. What that means is that we were OBGYNs to start with and then further subspecialized in fertility. This is a physician-owned and run clinic with a complete fertility care service, including intrauterine insemination, IVF, donor egg, donor sperm, and surrogacy treatment, some of which would be upcoming and discuss a little bit more in your future series. We also offer early pregnancy care and care for patients until they complete the first trimester. We are so lucky to have 3 full-time genetic counselors on site, which is essentially the core fertility treatment, if not all personalized medicine in the future. We are the only clinic in the whole of Ontario that do IVF and retrieval with deep sedation with an anesthesiologist on site, in person, providing safe care. We are proud to be affiliated with other clinics that are able to provide care for patients closer to home. This goes across to Oshawa area, Orillia, and now we're open in Barrie. In addition to it all, we have our medical director and quality director, Dr. Garcia and Dr. Weiss, that are both co-hosts of their own podcast called My Fertility Podcast, helping patients to demystify the world of fertility together. So what are we talking about today? We're going together be exploring what a normal cycle is. There's so many hormones involved in this pathway, and doing this in and out every day, I can see firsthand how individuals, couples, patients are mystified with hormones. We're going to make sense of some of the physiological signs and symptoms that individuals go through when you're having cycles. When we know what's normal, it then becomes a bit easier to spot what's not quite normal and discuss common presentations that have patients attend the general gynecologist clinic. If we're talking about what physiological hormones are, then birth control is all about hormones. We're going to talk a little bit about that. What is the menstrual cycle and why do we have them? The goal of having menstrual cycles and the goal of the game is to get pregnant. Menstrual cycle is the engine for fertility. The players that are in this game are your brain, ovaries, and uterus. And how do we have cycles and how is this game played is by the instrument using synchronized hormones that peaks and trough at different time of the month. So this choreographed dance of hormones from your brain affecting the ovaries, and then the downstream effects of those hormones to maturing eggs, thickening uterine lining, and potentially awaiting for implanting pregnancy. Even today in 2025, there are still lots of myths And for sure, cultural beliefs with regards to menstrual cycles. There are thoughts that menstrual cycles are ritually impure. There are women that are menstruating, they're considered to be not clean and restricted to enter temples, kitchens, or are separated from ritual bathing in more orthodox beliefs. There are other tribes that believe that having menstrual cycles is a rite of passage. It's a celebration of a girl's transition into womanhood. Native American tribes believe that having menstrual cycles are a source of power, that's spiritually powerful, closer to nature. It's sacred with its life-giving energy. It is also ridden with myths. Common ones that we hear all the time that I get asked in my office, am I okay to continue to exercise when I'm having my cycles? I should avoid it because so and so said that. Or that when you're having your periods, you cannot get pregnant. But that's not really true because it really comes down to how long your cycles are. And during those cycles, how long do you bleed for? And we'll unpack on that a little bit. This big one about period syncing comes around a lot, and that women that are sharing the same workspace, sharing a lot of daily routine, somewhat have their periods synced up. It's actually not a lot of evidence that prove that. Another big one, more and more coming up with social media, is the myth that there is this hormone balancing that needs to be achieved. The reality is that hormones peak and drop at different time of the month, and we'll talk about it more. And balancing hormone is not quite right. So what are the facts? Firstly, let's have some definition and some common trends that we see in Canada today. Menarche is what we call having your first menstrual period. The average age of menarche in Canada and most first world countries is around 12 and a half years old. We do find that this trend is getting earlier, so girls are getting younger and younger when they receive their first period. There's no true answer or evidence behind this, but it is thought that it may be the way that we live, the food that we eat, that may be a little bit higher in fat content. Menopause is when we have cessation, so no more periods for 1 year. Now, the difficulty with this is that it is a retrospective diagnosis. So you'll know that you have not had a period for 12 months in a row when 12 months is up. So it's not really one test that you can do to say that, there you go, you are officially in menopause until your periods have stopped for that amount of time. And the other thing to remember as well is that menopause, just like puberty, is not an on and off light switch. It's more like a dimmer light switch where you find that periods are starting to get further and further apart. There's a change in pattern, and eventually you have cessation of that. And this describes more of the perimenopause transition, which is that ill-defined time period leading up to menopause, and can last for some people not a long time, but generally around 4 to 8 years, where you have varied amount of symptoms, and some people go through it well. Some people do suffer from a lot of symptoms going through menopause. The average age of menopause in Canada is in line with other first world countries, around 51 years old. And if we talk about menstrual cycle, we should talk about female fertility a little bit. And I've put up a Russian doll image here because really when we are baby girls in our mother's uterus, that is when we have the highest number of eggs in our body. And that's around 20 weeks, and the amount of eggs there is around 6 to 7 million. When we are born, our egg count goes down to around 1 to 2 million. And what we know is that most of the eggs that we have go through a process called atresia during our childhood. So basically, we lose them. At the time of puberty, when we have our first period, we have around 300 to 500,000 eggs left. At 37, this is around 25,000. But what is normal? What does the normal cycle look like? Average woman in Canada have around 465 periods in her life. And if we do the math and think about each period lasting for around 5 days, that's around 2,300-ish to 2,500 days. That's around 6.5 years of your life if you were going to have periods every day. That's a lot of days to be bleeding from. And if you have bad periods, painful periods, heavy periods, there's a lot of days to suffer. On average, our cycles run around 21 to 35 days. So what that means is we define a cycle length with first day, your day one being the first full flow day. So a lot of people would think that first day is the day that they stop bleeding after they have a period, but day one is really your first full flow day. So if you count from your first full flow day until your next full flow day, that will be your cycle length. So that generally is around 3 to 5 weeks for most individuals with ovaries. Lasts around 3 to 8 days there, and it can vary even in the same individual around 2 to 7 days apart. And that would be considered as normal. How much should we bleed though? And this slide basically highlights the fact that this is poorly understood in general public essentially. So when Sally Ride, who was an astronaut, was flying into space, NASA came to ask her for her 1 week, is 100 tampons enough? And it highlights the fact that it's poorly understood. People don't know what normal flow should be like. But in general, it's around 20 to 85 cc per cycle. It's difficult to really measure the volume of blood loss though. Most individuals would report blood loss as the frequency they would change pads or tampons, and that's around 3 hourly and no more frequent than that. We seldom should be needing to change pads or tampons in the night and wake up to do that. Having clots when we're having periods are not unusual, especially understanding that the female anatomy has capacity in our vaginal wall to basically have some stretch and therefore allow blood to pool. So you find that clots do pool a little bit more overnight, and you find that you see a little bit more clots when you go changing position from sitting to standing. But clots generally should be less than 1 inch in diameter. We should not be experiencing anemia from our periods. And that usually are red flags to think about how heavy your periods are. Now to the sciencey part of organs and hormones. Who are the players in this game? The players in this game are the brain, which consists of the hypothalamus and the pituitary gland. The next big player obviously is the ovary, and the next big player is the uterus. And they work in communication with each other. So the hypothalamus and the top would be stimulating the pituitary gland. The pituitary gland is kind of like the control center for hormones signaling in our body. So it doesn't act only on our reproductive organs, also acts on our kidney, our thyroid glands, our bones, breasts, and obviously for male individuals, their reproductive organs would be their testicles. How do the players work? They work using the arsenal, which are the hormones. The hypothalamus on the top would be releasing a specific hormone called gonadotrophin releasing hormone. In short, it's GnRH. GnRH stimulates the pituitary. Pituitary gland releases a bunch of other type of hormones, but namely for the purpose of this talk, it secretes a follicle-stimulating hormone and luteinizing hormone. So in short, FSH and LH. Both of these hormones work on the ovaries. Ovaries produces estrogen at the first part of the cycle and progesterone at the latter part of the cycle. And those are the two most important ones. There are other hormones that are less talked about. Estrogen and progesterone work on the uterine lining, called it the endometrium. And endometrium, if there was a pregnancy that happens, will produce pregnancy hormone called HCG. And all this have the sort of negative feedback telling the organ before it and signaling to tell them that, okay, I'm working, I'm responding. So in short, what are their jobs? We talked about those sequential way that they work in the axis. So GnRH secreted by the hypothalamus would stimulate the pituitary gland downstream, acts in a pulsatile manner. And the pulsatile manner in the way that it acts is important. So blunting of the pulsatility has an effect on the downstream hormone. FSH, the name of this hormone is exactly as the label suggests on the tin. What does it do? It's a follicle stimulating hormone. So it stimulates follicles, and follicles live in ovaries. Luteinizing hormone is one that is picked up in your home ovulation testing kit. Lutein means yellow in Latin, And the corpus luteum is a yellow body, and this structure occurs post-ovulation. Estrogen stimulates the thickening of the uterine lining. Progesterone is made by ovaries after ovulation, and it maintains the uterine lining. Look at this picture and you can see how the hormone pathway and organs are in line here, and they work in a synchronized way. So GnRH in the hypothalamus stimulates the pituitary stimulates the ovaries produces estrogen, and it feedbacks negatively to the organs in front of it to say, I'm working, you don't need to work on me so hard. But at the same time, I'm also telling the uterus it needs to thicken up its lining. At some point, estrogen level will become high enough that it positively feed back to the hypothalamus and pituitary, and you'll have a surge of ovulation. Now, all this thing happened in synchrony. So if we follow this picture, we know that our cycles generally is cut into two phases. The follicular phase, which is when the follicles and the ovaries grow. The second part of our menstrual cycle is the luteal phase. The luteal phase would describe a cycle after ovulation. The dominant hormone in our follicular phase is estrogen. The dominant hormone in our luteal phase is progesterone. So we can see here, if you follow the light blue line to start with, and that's your FSH. FSH starts, and FSH stands for follicle stimulating hormone. Follicle stimulating hormone would stimulate follicle. And you can see the ovarian cycle that the follicle growing. As the follicle grows, estrogen rise. And as the estrogen rise, womb lining thickens. So womb lining is the endometrium in the third picture there. Estrogen would rise to a point and signals to the brain that follicles are big enough now, it's ready to ovulate. You'll have a surge in luteinizing hormone, and this is that hormone we talked about that we can pick up on home urine testing sticks, on ovulation sticks. And this is the purple line. This goes up very sharply and comes down very sharply, and is present only for a very short amount of time during our menstrual cycle. Usually this is in the middle of the cycle, about 2 weeks before you receive your period. You can see in the picture that this also signals to the ovary now to release the egg. So this is ovulation happening. As ovulation happened, the corpus luteum would now produce progesterone, which is the green line that you'll see on the top curve. Corpus luteum that produces progesterone also changes the womb lining. Now it's not just thick, it's thick, fluffy, and secretory. It's waiting for an implanting embryo. The egg that's released now has an opportunity to meet with the sperm if unprotected intercourse has happened and fertilization has occurred in the fallopian tube. And this fertilized egg, now an early embryo, will continue to divide as it moves down into the uterine lining to try and implant. If implantation doesn't occur or there's no unprotected sex, then the corpus luteum would lose its signal because there's no pregnancy hormone that's stimulating it. As the corpus luteum loses its signal, it also loses the progesterone secretion. So the factory stops working, progesterone stops, womb lining does not get the signal anymore that it needs to be supported. Womb lining would shed, your cycle would come and presents as a period bleed. The whole cycle starts again. Let's break down some of the symptoms that we might experience when we're going through different phases of the menstrual cycle. So this is the follicular phase. Follicular phase is when the follicles are growing, estrogen is rising. We would have started our period, finished with our menstruation, usually, like we said just now, around 3 to 5 days. As estrogen level rise, we also find that we may see increasing energy level, that our mood gets better. We also find that as our period stops, that we have that reduced sensation of bloating. People find that as the energy level increases, they also may have improved concentration. Stress level might be found to be a little bit lower, and exercise performance better. Estrogen is also associated with feeling that our skins are better, our hair thicker, and this is sometimes seen in people that are having hormone replacement therapy. You find that you might be a little bit more optimistic, sociable, and find that as we're preparing to be ovulating, that vaginal lubrication and comfort also gets better. Then comes the middle of our cycle when we ovulate. Some individuals and people would experience brief and mild pain or cramping when they ovulate. And this is a well-known phenomenon, and it's got a name to it. It's called middle smirts. And that can be quite noticeable for some people. We find that as we're ovulating, there may be changes in our cervical mucus. The consistency and the color of the cervical mucus may change during ovulation. It often becomes clear, slippery, and more stretchy, resembling egg white, which is a common description for it. This type of mucus facilitates sperm movement. As the eggs being released, we might find that there's increased libido because of hormonal changing, particularly because there's a surge in estrogen level. This may lead to increased libido and some increased sexual desire during ovulation time. You might find that also there is an increasing sensation of breast tenderness, some abdominal bloating, and heightened senses. There are some individuals that have ovulation pain that's not just on one side, but may affect both sides of the pelvis, and increase in basal body temperature. And you hear this quite a lot, that people may go ahead and do this to measure whether or not they are ovulating. The difficulty with this is that it requires quite religious tracking of your basal body temperature first thing in the morning. It is a little bit subjective. It can be affected by environment. And also the most important thing is that you see that slight increase in basal body temperature after ovulation because the influence of progesterone. So you may find that this is not the most helpful in having to time your fertility window because ovulation's already occurred. We may find that our mood is changing with ovulation and now with some progesterone coming into the system. And that because of the little bit of a drop in estrogen level after ovulation, that the womb lining can change. And because of that, some people may find that they experience a little bit of spotting in the middle of the cycle, and that can be normal and physiological. Now come to our luteal phase. Luteal phase is that second phase of the latter phase of our menstrual cycle that is predominantly progesterone heavy. And so a lot of the symptoms that we're describing are symptoms of progesterone. Commonly, people would complain of breast tenderness because of the progesterone increase that can cause breast tissue to become more sensitive and swollen. Bloating is one big one. The hormonal fluctuation may lead to water retention, result in the feeling of bloating and some weight gain. You might find that we're a little bit more fatigued. We find that mood swings are a little bit more common in this time of the cycle, where there are changes of estrogen and progesterone levels can affect the sort of neurotransmitter in the brain, leading to a little bit more irritability. There is other common things with progesterone influence, which are skin changes, acne, because of the oil production in the skin that leads to more breakout. Another common one is headaches. Not unusual that around this time that there's a lot of trigger for headaches, especially for individuals that already experience migraine anyway. Food cravings is one big one. Quite different, and some of these symptoms are quite subjective and may not affect you all the way and all the time, but something to be looking out for. And whether or not your sleep might be just a little bit more disturbed, you might be a little bit more sensitive. We've now covered what normal looks like. We've covered the big players, the organs, the hormones, what normal flow, normal cycle, length will look like. And then now it's easy then to spot what's not quite normal and how these are common presentation to GYN office. So heavy periods is sort of the bread and butter of gynecology practice, and unfortunately all too common, and also being tolerated and experienced by and put up by women. Painful periods is another one. Outside of heavy and painful periods, some people experience this on a really cyclical basis, which makes us think whether or not there's an association to conditions such as endometriosis. There is another common presentation is cycles being irregular or absent. So this pattern that you cannot recognize. If you try to plan your family, you don't really know when to time intercourse, or that intercourse is painful. Other symptoms that we talked about just now are really severely affected individuals with the swinging of these hormonal changes that we talk about causing mood changes, skin changes, and weight changes. And rightly so, a lot of common presentation with contraception too. So if we know that some of the symptoms and signs that patients bring themselves to a GYN clinic, let's talk about a little bit on how gynecologists, you expect them to work you up in a clinic setting. The story that you tell us when we do your history taking is written with clues to help us sort of figure out what's the likely reason for the symptom that you're presenting. Examining abdomen and pelvis, speculum examination, and internal examination gives us some clue too. But in essence, what we're trying to figure out with the symptoms that you're presenting is whether or not this is a structural cause or non-structural cause. And some examples of structural causes to symptoms that we talked about are things like polyps, adenomyosis, fibroid, overgrowing precancerous cells of the womb lining or cancerous cells of the lining. Non-structural things, so things that we can't see, could be disorder in ovulatory cycles, blood clotting problem, or what we call iatrogenic, so potentially herbs, medication that you're taking that's causing the disruption in your bleeding pattern or the bleeding flow. And because we're trying to look for things that are structural, using some kind of imaging would help us reach that diagnosis. So commonly, it would be an ultrasound of the pelvis. And the easiest way to look at the female pelvis and the most sensitive way to do that is using a transvaginal ultrasound scan. There would be blood work and lab work that we can do to look at your hormone panel, look at your blood count, and try and figure out what is causing this and what the effect of it is and how bad is it. Occasionally, we need to do tests that are a little bit more invasive, and that could involve taking a sample of the endometrium by biopsying it, or a procedure called a hysteroscopy, where we pass a really small camera that looks like a telescope that goes into the cervix, into the uterine cavity, and directly visualize the cavity itself. For the female athlete, there are some other unique presentations. So in individuals that are having high caloric output, low caloric intake, there may be a negative energy availability balance here. This could lead to a reduction in the pulsatility of the hormone that's produced by your hypothalamus. Remember, we talked about it in the first place just now. The hypothalamus is at the top in the brain. It's producing gonadotropin releasing hormones, so GnRH, that then signals your pituitary downstream. But this reduction in the pulsatility, where there's a blunting of this hormone, can lead to downstream hormones not being produced. If you don't have the signal from the top, then you don't have the downstream signal. So this would lead to no follicles growing, no follicles ovulating, womb lining not thickening, no progesterone. And so that presents as cycles becoming irregular because ovulation is not regular. And with that, periods don't come because womb lining don't grow. And essentially, there's a menstrual dysfunction here. In addition to the loss of periods or the irregularity of periods here, estrogen also works on our bone metabolism. So the lack of estrogen and the cessation of periods can lead to low bone mineral density over a long amount of time. And because of this, this would increase risk of osteoporosis and fracture. And bearing in mind also that majority of your bone mass is accrued at the end of adolescence. So if we're seeing a lack of estrogen as a result of irregular cycle or non-ovulatory cycle, this could affect younger female athletes too with low bone mass. Lastly, we're going to touch a little bit on hormonal birth control. Hormonal birth control, typically what the general public knows is that it occurs in a pill form. The way that it works primarily is to suppress ovulation. And this is achieved through the combined action of synthetic estrogen and progesterone. So we call that progestin hormones. So this suppresses gonadotropin. So mainly what we talked about just now, FSH and LH, and prevents the release of an egg from the ovary during menstrual cycle. This can also alter the womb lining and reduce the likelihood of implantation. Now, when we think about hormonal pills, we think about it for its birth control purposes only. But there are other benefits of contraception in the hormonal pill form. It can help patients and individuals that have no cycles or very heavy cycles to control their cycles, but that would prevent a pregnancy if there was an unwanted side effect. In individuals that have a lot of peak and trough with their mood and mental health as a result of being severely affected by the natural cyclical peak and trough of hormones, having hormonal birth control can help them too. It reduces the risk of endometrial cancer because your womb lining don't overgrow. It also reduces the risk of ovarian cancer because you're not cycling and you're not having this sort of turnover in ovulation. In a lot of patients that are suffering from excessive hair growth, acne, and have a condition called polycystic ovarian syndrome, using birth control to help them can improve these symptoms. In addition to all that we talked about in the last slide, which is bone health. So if you are not having regular enough cycles because of a low energy availability, the risk of osteoporosis can be reduced slightly with taking birth control pills. To conclude, the menstrual cycle, flow, and regularity give us a lot of clue about our fertility health. And it can vary quite a lot between individuals, but also acceptable for within the same individual to vary a little bit here and there. Hormone peaks and troughs are part of normal cycle. So taking birth control pills actually blunts it. It's important to know what's normal because it helps us to recognize what is abnormal. And knowing that we can have open conversation, increases awareness, it reduces shame and sufferings of people that are having abnormal cycles and bring them to see a doctor sooner. Lastly, having knowledge and resources empowers your decision making. Make a decision that's right for you at the right time of your life. It was my pleasure to talk to you today.
I see a question here. One of my teenage athletes has asked if anorexia or bulimia can affect periods and their cycle. What can I tell them?
It can. It's one of the common way that it can blunt the pulsatile hypothalamic hormone level. So the answer to that question is that it can because of the low energy availability, and it blunts it. The important thing is actually to look out for these conditions that can happen, and not only in the athletic world, but more also in these age group in general. Awareness is one, having good resources and having no shame around this to make sure that we're supporting best we can. And the other thing is sometimes using treatment, healthy eating, body image, and then considering other medical care. So using birth control is one. And in some cases that are resistant, where we do see bone health that are being compromised, they may have to have some hormone replacement. And that comes in a patch form.
Thank you. I have another question too. You mentioned the benefits of taking birth control in terms of having like some prevention cancers. And I wondered what the research is on other methods of birth control, like outside of taking birth control pill. Is there also any relevance in terms of like an IUD or a patch or all the other different kind of methods?
Yeah, good question. Largely, birth control are divided into two categories. So the first category is what we know most commonly, which is birth control that consists of estrogen and progestin, so both hormones. The other category is progestin only. So like the IUD is a progestin only. The hormones are just these two groups. The other ways that you talk about in sort of trying to divide them is the delivery system. The delivery system comes in a pill form, comes in an injectable form, comes in a intravaginal ring form, comes in an IUD that goes into the uterus. So the categories of the hormones, there is two hormones or one hormone. All the other stuff is how it's delivered to you. The pill form comes in both, so you can have it progestin and estrogen and progestin only. The ring is both. The IUD is progestin only. The injection is progestin only. And they tend to be also called the longer acting reversible contraception. So it's not like a pill, it's short acting, you have to take it every day, you have to remember. The IUD you can put it in for 5 years, 7 years. The injectables 3 monthly. So they're longer acting.
Okay.
Mm-hmm.
Interesting. Yeah, there's so many options, I feel like now.
Yeah. The broad category is there, which is the hormones are the are largely the same.
Right.
It's how it's delivered to you and how long it lasts.
We have another comment here. This is a comment, but the Fitter Woman app is a research-based app that helps plan training with the menstrual cycle. Okay, I have heard of that, but I haven't tried it yet. So this is actually a good reminder for me to do that.
Huh, I haven't heard of it. I'm going to check it out.
And then just to build off of the question that was answered earlier, for those people who have potentially lost their periods for a number of different reasons, are there long-term consequences even if they have their period again? Is there long-term consequences of having lost their period for a long stretch of time?
Difficult to say because it comes down to what the cause is. And that's the important part. So if you are somebody who has already gone through menarche, having had your first period and having regular period, and suddenly your period has stopped, essentially what we need to make sure is that we work out why and where in the pathway has caused it to stop. Is it because you have low calorie availability? Do you have polycystic ovarian syndrome? Is there scar tissue that's formed? So we need to figure out what is the cause first. So I think the first step is always to make sure that you seek help. And unfortunately, even diagnosis like premature menopause can happen in younger women. And
Right.
you might not know. You think that your period has stopped because you're over exercising, you're feeling hot and
Yeah.
flushy because you're out exercising and working out in the heat. But actually, you're 25 years old and your hormone pathway has closed shop because you ran out of eggs early and you might have swept it on the carpet. And women has more of that tendency to
Right.
over explain, so but make sure the first thing is that we know what's normal. We now know what abnormal looks like, and make sure that you seek help and find out a diagnosis.
Thank you. That's great advice.
We'll wrap it up now and just thank everybody for coming, for joining us in the Markham Fertility Center. Thank you so much for another wonderful and informative webinar.
Thank you so much.
Thanks for having me.
Thank you, Dr. Chong.
Bye.
Bye. See you soon.